بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we are going to discuss one of the important and difficult issues in brain imaging, whether it belongs to the adult brain imaging or the pediatric brain imaging, which is the diagnosis of white matter diseases. And this is a very big subject, and we will handle this subject on three parts. The first one will deal with the congenital white matter lesion. The second one will deal with the acquired white matter diseases. And the third part, which is, in my opinion, the difficult one, will handle the metabolic white matter disease. First of all, I would like to show you some of the important aspects about the myelination of the white matter. Actually, the myelination proceeds intrauterine and after birth until the age of 2 years. And many times we are confronted by MR examinations to report or to say the state of myelination of the white matter. Then we should know that the full-term baby will have at birth these anatomic structures are myelinated. The medulla oblongata, the dorsal aspect of the midbrain, the posterior limb of the internal capsule, the anterolateral aspect of the thalamus, and the deep part of the centrum semiovale. By the age of 3 months, there is myelination of the bones, myelination of the cerebellar folia, and the ventral aspect of the brainstem, as well as the optic radiation, the occipital cortical U fibers, the splenium of the corpus callosum, and the anterior limb of the internal capsule. Then, by the age of 6 to 8 months, there should be myelination of the whole brainstem, most of the centrum semiovale, except some areas in the frontotemporal lobes, and all the subcortical U fibers by this time will be myelinated, as well as the genu of the corpus callosum. Then we have the white matter disorders classified into the primary white matter lesions or the leukodystrophy, the acquired white matter disorders of both gray and the white matter, and those affecting the basal ganglia. The first issue comprises a lot of diseases, and in this part of the lecture we'll discuss the first 6 pathologies: the metachromatic leukodystrophy, the Krabbe disease, adrenoleukodystrophy, Pelizaeus-Merzbacher disease, Alexander disease, and the Canavan disease. Then we will have some, in the third part of this talk, we'll discuss the disorders of the gray, white, and the white matter lesions, including Leigh's disease and the Melas syndrome. And also we'll have some words about the basal ganglia disorders, including the Huntington disease, Farr disease, and the Wilson disease. Then what do we mean by leukodystrophy or dysmyelinating disease? Of course, The word dysmyelinating means that there is abnormal formation of the myelin or abnormal destruction or turnover of the myelin sheath which covers the axon of the neuron. And this is a wide group of diseases, as you know, and they have different underlying pathologies. But each of these diseases may have its own clinical presentation. But most of these leukodystrophies have a common clinical findings in most of the cases, like I have listed here. Number one, these leukodystrophies are predominantly seen in infancy and childhood, although you may see some juvenile forms of each disease and also adult forms of each disease. But you should know that in children, the course of the disease is usually rapid, causing death relatively quickly, while in adults, the course of the disease may last for many years. The symptoms include hyperirritability and hypersensitivity, muscle rigidity, and backwards bend of the bent head, mental retardation, and epilepsy, which is a common finding in most of the cases, optic and auditory affection. These are the common findings we may see in every of these diseases. We'll start first by the almost the most common type, which is the metachromatic leukodystrophy. And as I have mentioned, you may have commonly an infantile form, then less commonly you may have a juvenile and adult onset forms. This leukodystrophy is secondary to an enzyme deficiency leading to accumulation of sulfides in various organs, including the CSF, and this will impair the accumulation or the process of myelination. Then sulfides have characteristic histologic staining and hence the name metachromatic. The metachromatic is the name referring to the stain type for histologic assessment of this disease. Then this is the well-known, most famous one of leukodystrophies, which is the metachromatic leukodystrophy, and the prevalence is, as you can see, 1 in 100,000 newborns. There, all these diseases affect the white matter almost symmetric, and the affection of the white matter will appear in the CT as extensive hypodensities within the white matter. And in MRI, it will show low signal in the T1 and high signal in the T2 and the flare weighted images. The behavior towards contrast in injection differs from disease to another. And there are some of the, let's say, characteristic findings that can help sometimes to predict the nature of the disease. Then this disease affects the white matter. This is a FLAIR image showing diffuse high signal in the white matter of both cerebral hemispheres, which is almost symmetric. One of the criteria of this disease is that a sparing of the subcortical U fibers. If you look carefully here and you see the edge of the white matter is not affected, it shows low signal, it's still showing low signal, meaning that it is not affected. And this is what we mean by sparing of the subcortical U fibers. This disease starts anteriorly, then progress posteriorly, while other diseases will start anteriorly, posteriorly, and progress anteriorly, as we will see. Then the cerebellum is often atrophic, and the age incidence in most of the cases is in the range of 1 to 2 years. And the CT findings of metachromatic leukodystrophy is just abnormal hypodensity of the white matter. And you see, the white matter is hypodense. You cannot know that the subcortical U fibers are spared except in MRI. Then if you inject contrast media in this particular disease, you will see no enhancement. And the MRI findings of metachromatic leukodystrophy will include high signal in the T2 and the flare of the white matter around the ventricles. The subcortical U fibers are spared. Then you see these white matter, the edge of the white matter is not affected. Then the thalami may appear hypointense. As you can see, these are the basal ganglia, but sometimes you may see hypointense signal in the thalami. And this is metachromatic leukodystrophy, MRI T2 and T1 post contrast. Of course, no enhancement will appear in the post contrast images, but in the T2 weighted images, you see that there is a confluent high signal intensity of the white matter around the ventricles with relative sparing of the subcortical U fibers. And this is also a case of metachromatic leukodystrophy, MRI T1 weighted image and T2 weighted image. And you see the edge of the white matter appears of low signal, meaning that the subcortical U fibers or the edge of the white matter is spared. Then one of the features of this metachromatic leukodystrophy and also the other disease, which is Merzbacher, is the presence of low signal lines within the affected white matter, giving the characteristic tigroid appearance of the white matter. This is a prominent feature in Merzbacher disease, and it may be also seen in this metachromatic leukodystrophy. But you know that in cases of metachromatic leukodystrophy, the U fibers, the subcortical U fibers are spared, while in Merzbacher, the subcortical U fibers are not yet myelinated at the time of onset of this disease. Then, to sum up the informations about metachromatic leukodystrophy, this is considered the most common type, and the age is usually in the range of 1 to 2 years in most of the cases. It spares the subcortical U fibers, and you see this is one of the criteria. It progresses from anterior to posterior, and the tigroid pattern of the demyelinated white matter with multiple low signal lines within the white matter is one of the criteria. And if you inject contrast, there will not be enhancement. And we came to the second disease, which is Krabbe disease, and this is considered a rare disease, and the clinical presentation is somewhat similar to the general presentation I have mentioned, including psychomotor deterioration, irritability, optic atrophy, cortical blindness, and the seizures in later stage. The disease is related to an enzyme deficiency leading to accumulation of cerebrosides in the white matter, and this will impair the process of myelination. Then the CT findings in this disease are almost characteristic compared to the findings on MRI. And you see diffuse hypodensity of the white matter, but the presence of hyperdense thalami and basal ganglia on the unenhanced CT scans is one of the criteria of this Krabbe disease. And if you inject contrast media, there will no enhancement. And if you look to the brain, you can see some atrophic changes in the form of dilatation of the ventricles and the prominence of the extraaxial CSF spaces. Although we know that in this age, on the age of 3 years, the brain will appear almost similar to that of the adult, with normal ventricles and normal cortical sulci. We can accept this appearance in the neonatal period and up to the age of 2 years, where the brain is still growing and you see that the ventricles are dilated and the cortical sulci are prominent. We consider this as normal finding below the age of 2 years. But at the age of 2 years onward, then you should see the brain similar to that of the adult. Then this is a 2 years old male, and this is evident atrophic brain changes in the form of dilatation of the ventricles, prominence or dilatation of the extraaxial CSF spaces. And if you look carefully, and you can see some increased density within the thalami. And this is also a case of Krabbe disease, and you see hyperdensity within the cerebellum, hyperdensity within the thalami, and also within the deep part of the corona radiata. At the age of 4 months, you are not able to predict whether these are normal changes according to age or this is atrophy. We cannot say that unless we reach the age of 2 years. Then CT is more helpful in the diagnosis of Krabbe disease since the MRI findings are almost similar to any of the white matter diseases, like increased signal intensity of the white matter in T2 and the FLAIR weighted images. The subcortical U fibers are spared until very late in the disease. And if you look carefully here, and you may see that there is some sparing of the subcortical U fibers. Then if you inject the contrast, there will not be any enhancement. Then this disease is very rare. The onset is almost similar to metachromatic leukodystrophy below the age of 2 years. The CT is more sensitive than MRI in detection of affection of the thalami. The brain will show some atrophic changes. In the non-contrast CT, the thalami will appear relatively hyperdense, and if you inject the contrast media, there will be no enhancement. Then the third one is the adrenoleukodystrophy, which is an X-linked disease seen only in males between the age of 3 to 10 years. Then the clinical manifestations are almost some of the previously mentioned, like seizures, hearing loss, spastic quadriparesis, and some of the visual and behavioral disturbance. Where this disease has a very characteristic imaging finding when in the typically appearing cases. The findings include affection of the posterior white matter in the parieto-occipital area around the trigone and occipital horns of the lateral ventricles. Affection is almost symmetric, and the CT scan it will appear like hypodensity affecting the white matter. And if you inject contrast, you'll see that the edge of the lesion will show characteristic marginal enhancement. And on CT scan, you may be able to detect some calcium in the edge of the lesion. Then this is the MRI findings. The posteriorly located white matter around the trigone and the occipital horns of the ventricles is selectively affected, and it will appear of low signal in the T1 and high signal in the T2 and the flare weighted images. If you inject a contrast, then there is enhancement of the peripheral margin of the lesion. And this is an example of adrenoleukodystrophy, low signal lesions posteriorly located around the trigone and the occipital horns of the lateral ventricles. And in T2 weighted image, the lesion will appear of high signal with relative sparing of the subcortical eufibers. If you inject contrast, the edge of the lesion will show characteristic enhancement. And this enhancing edge is known as the leading edge and is suggestive of the presence of active inflammation. And in this particular example, you see the posterior white matter is involved with relative sparing of the subcortical U fibers. There is involvement of the splenium of the corpus callosum, and the lesions are bright in the T2 and the flare weighted images. And after contrast enhancement, then you see that the edge is enhancing. And this is an example of adrenoleukodystrophy with characteristic MRI appearance, posteriorly located white matter abnormalities, and whenever you inject contrast, there is enhancement of the leading edge, indicating the presence of active inflammation. And of course, you know that all the previously mentioned diseases may have an adult form or juvenile form, but the common age incidence in metachromatic leukodystrophy is below the age of 2 years. In Krabbe disease, below the age of 2 years. In adrenoleukodystrophy, it is in the range of 3 to 10 years. And this is an example of adrenoleukodystrophy by CT, MRI T1, and MRI FLAIR, with the characteristic appearance of the posteriorly located white matter changes, hypodense in the CT, low signal in the T1, high signal in the FLAIR, and after injection of contrast, you got the typical enhancement of the leading edge of the disease, which, as I have mentioned, an indication of active inflammation. Then, to sum up the information about the adrenoleukodystrophy, this lesion is a sex-linked leukodystrophy occurring only in boys between the age of 3 and 10 years. There is symmetric involvement of the bright occipital region. There is enhancement of the leading edge after contrast injection, and calcium can be seen especially, of course, in the CT scans. Then we came to the Blasius-Merzbacher disease, which is considered a rare neurodegenerative disorder occurring also in boys as an X-linked leukodystrophy. This disease will affect the development of myelin and will arrest the myelin development. Then the CT findings are not characteristic. You see diffuse hypodensity of the white matter, and the cortex, of course, as in every disease, is usually intact. But the MRI findings will show similar changes, widespread involvement of the white matter, which will appear of low signal and the T1 and the high signal in the T2 and the flare weighted images. If you inject a contrast, there will be no enhancement, and in this particular disease, similar to the metachromatic leukodystrophy, the basal ganglia and thalamus may appear hypointense on T1 weighted image, and this is suggested to be due to iron deposition. And the tigroid pattern is a prominent feature of this disease. And you see the white matter with a multiple linear low signal and low signal intensity within the demyelinated white matter. And this is the difference between the metachromatic leukodystrophy and the Blasius-Merzbacher disease. In both metachromatic leukodystrophy and the Blasius-Merzbacher disease, the tigroid pattern is one of the features, although in the later one it is prominent. The U fibers are preserved in metachromatic leukodystrophy, while the U fibers are not yet myelinated in the Blasius-Merzbacher disease. Then the appearance of Blasius-Merzbacher disease by MRI, as I have mentioned, you see diffuse involvement of the white matter with the characteristic tigroid pattern, which is explained by the presence of islands of myelin around the penetrating vessels. There is myelin, some preserved or intact myelin around the penetrating vessels, which will appear of low signal within the unmyelinated white matter, giving the tigroid appearance, and the thalami are of low signal intensity in T2 weighted image, as I have mentioned, due to the iron deposition. Then this is a rare disorder and it affects boys similar to adrenoleukodystrophy, and the white matter exchanges are almost similar to the metachromatic leukodystrophy, including the tigroid pattern of the white matter. Then we came to a rare disease, which is the Alexander disease, and this leukodystrophy is of unknown etiology, and it has an infantile form and also the juvenile and adult forms. The clinical presentation depends according to the age of presentation. In the infantile form, there may be megalencephaly, mental retardation, spasticity, and seizures. And of course, the disease is rapidly progressive in the infantile age incidence, and the death may occur within 2 to 3 years. The juvenile form the onset may be between 7 and 14 years with progressive bulbar symptoms and spasticity as well, while the adult form may be seen up to the seventh decade of life and it will show manifestations similar to the MS. The characteristic appearance of this disease on CT and MRI is the predominant affection of the frontal white matter. The white matter is affected, but the main brunt will appear in the frontal lobes. The basal ganglia will show low density, and if you inject contrast, there is enhancement in this disease. This enhancement will affect some of the areas of demyelinated white matter and also the basal ganglia. Then for the diagnosis of Alexander disease by MRI, you need to have 4 of 5 criteria. Number one, extensive, particularly the frontal lobe white matter changes. You see here the white matter in the frontal lobe is much more affected, while the white matter in the occipital area is almost intact. Periventricular rim of bright T1 and dark T2. If you look carefully here, and these small arrows point to this rim, which is of dark T2, this very small rim of dark T2 and bright T1. Then brainstem abnormalities and the basal ganglia affection. And if you inject to contrast, the basal ganglia and some of the affected white matter will enhance. And the predominant affection of the frontal lobe may suggest the possibility of Alexander disease. And in most of these cases of white matter disease or neurodegenerative diseases, in order to reach the final diagnosis, you may need to have a brain tissue biopsy to be sure about the nature of the specific disease. Although the MRI, diffusion weighted images, and MRI spectroscopy may help to predict the nature of the disease, but in order to be sure about the diagnosis, you may need to have a brain tissue biopsy. And this is Alexander disease with predominant affection of the frontal white matter, showing low signal in the T1 and high signal in the T2. The basal ganglia are also involved. You see hypointensity in the T1 and hyperintensity in the T2. And after contrast injection, there is prominent enhancement of the basal ganglia. And this is also a case of Alexander disease with predominant affection of the white matter in the frontal lobes, and there are cystic changes. And you see these low signal structures, which are high signal, and in the frontal uh, white matter. And if you inject the contrast, you expect to see some of the enhancement within the affected white matter as well as in the basal ganglia. Then you remember the periventricular rim of high signal in the T1 weighted images and low signal in the T2 weighted image, which I don't know an explanation for it, but it is considered one of the criteria of Alexander disease. Well, you know that, as I have mentioned, you have the juvenile form and the adult form. The juvenile form may present between the age of 7 and 14 years old, and this is an example. There is affection of the basal ganglia and the predominant affection of the frontal white matter. Then to sum up the informations about the Alexander disease, this is a rare disease, and it typically presents in infants similar to the rest of the previously mentioned. It affects the white matter, especially that of the frontal lobes, and there is abnormal signal of the basal ganglia and thalami. If you inject contrast enhancement, there will be enhancement of the basal ganglia and some of the affected white matter. Then you remember that up till now, there are only two diseases which can show contrast enhancement, and these are the adrenoleukodystrophy with enhancement of the leading edge indicating active inflammation, and the Alexander disease with enhancement of the basal ganglia. Then finally, we came to the last one of this group, which is the Canavan disease, and this is also the spongiform leukodystrophy. This is also a rare disorder with no gender predilection. It selectively involves the subcortical white matter. This disease particularly affects the subcortical white matter, while all the previously mentioned diseases tend to spare the subcortical white matter. Also, the disease starts in the occipital lobes and progresses to the frontal area, while most of the previously mentioned diseases start in the frontal lobe and progress posteriorly, except the adrenoleukodystrophy, which is predominantly located in the occipital area. Then in this disease may spare the internal capsule. Uh, this will result, the enzyme deficiency will result in accumulation of N-acetyl aspartic acid. And this is the accumulation is neurotoxic, leading to vacuolization and spongy degeneration of the white matter, and hence the name of the disease. Then the clinical presentation will depend on the onset of the disease. Most of the diseases are seen in infants, while There are some forms occurring in the adolescent and adult age. The infantile form, which is the most common, is seen around the age of 3 to 6 months and presenting by hypotonia, macrocephaly, seizures, and optic atrophy. Then this disease will show diffuse affection of the white matter extending to the periphery near the cortex with a predominant affection of the subcortical U fibers and CT scan, we will see diffuse hypodensity of the affected white matter, while on MRI, you see that the lesions of low signal in the T1, high signal in the T2, and FLAIR images. If you inject contrast, there will no be enhancement of the affected white matter. Then the subcortical white matters or dew fibers are predominantly involved. The ventricles are of normal size, no atrophic changes, and the internal capsule may be spared in this disease. And here, an example of Canavan disease with involvement of the subcortical U fibers and the vacuolated appearance of the white matter with multiple cyst-like changes which represent dilated Virchow-Robbins spaces secondary to degeneration of the white matter. And in the T1 weighted images, you see the affection of the periventricular white matter and in the frontal and the occipital lobes. You may feel that the occipital lobes are more prominently involved, and it is easy to see the cystic changes in the white matter, which are of bright signal in the T2 and low signal in the T1, which indicates dilated Virchow-Robbins spaces secondary to degeneration of the white matter, and this will lead to the what is known as spongiform degeneration of the white matter. In Canavan disease, the white matter is involved, particularly the white matter in the occipital lobes. The thalami and the brainstem are also affected, and in this particular case, you see some atrophic changes. This is a male, 9 years old. The cortical sulci in this age, in this patient, are prominent, and the ventricles are more or less of normal size. And the Canavan disease affects the white matter, particularly the arcuate U fibers, and it is more evident in the occipital area compared to the frontal area. But in this particular disease, you may feel that the frontal lobes are more involved than the occipital lobes. And you know that there is an overlapping findings between the previously mentioned diseases, and that's why you may sometime need to have a tissue biopsy to confirm the diagnosis. Canavan disease is a rare disorder with no gender predilection. It is commonly affecting infants between the age of 3 to 6 months. It is let us say, the only one which is selectively involves the subcortical U fibers. It starts in more evidently in the occipital lobes, and the internal capsule may be spared, maybe sometimes. The affected areas will show restricted diffusion, and if you inject the contrast, no enhancement will be seen. Thank you very much. Alhamdulillahi Rabbil Alamin.